Upon assessment, it is noted that the client is well-groomed, dressed in a casual suit and tie, with no physical stigmata. He uses appropriate eye contact and is cooperative throughout the intake interview. He sat comfortably in the chair with his hands folded in front of him and his legs crossed, occasionally playing with his tie. He appeared to be slouching at times in the chair with his head down, but most of the time he was making good eye contact. Scotty's speech was hesitant at times, exhibiting a decreased reciprocal flow by using direct, succinct answers to questions without further elaboration on his own. The client is from Pennsylvania and has a very distinct regional dialect, though his inflection and articulation have been assessed as normal. Scotty describes his mood as distraught in this intake interview. The client's blunted and somewhat dysthymic affect is congruent with his stated mood, while his mobility is within the normal range. He reports having some obsessive thoughts in which he ruminates on his feelings of guilt regarding both deaths that he had witnessed. He says he worries about when his acrophobia is going to manifest next. He said, "If I dropped a pencil on the floor and bent down to pick it up, it could be disastrous." At the time, I do believe that he was joking around, but it is a real concern for him. The client denies having any hallucinations, perceptual, or attention issues. He is oriented to person, place, time, and situation. As a former detective, Scotty has been trained to rely on remote, recent, and immediate memories, and therefore does not seem to have any trouble with recollection. He says, in fact, that he wishes his memory wasn't quite as good as it is, so that he could stop vividly remembering his traumatic experiences. The client seems very insightful and has an excellent recognition of problems and their origin within. He sought assistance immediately and of his own volition, though he reports having some encouragement from his former fiancé and current friend. Scotty has suffered many great losses recently, including his occupation as a detective, his ability to function in stressful situations, especially in high-rise buildings or high places, and the deaths of his colleague and loved one. He does not show any signs of suicidal or homicidal tendencies, so there was no immediate threat to life, but again, that must be monitored because of his depression. Scotty developed major depressive disorder, post-traumatic stress disorder, and acrophobia within 3 months after the life-threatening events occurred on the rooftop when he witnessed the death of his colleague. He was 49 years old when this happened, and he did not have any symptoms of these disorders before that unfortunate incident. The symptoms of post-traumatic stress disorder intensified in response to the trauma of the apparent suicide and actual suicide of the significant other in his life. In this case, there is the need to establish that the patient is committed to treatment and is willing to tolerate some intensification of symptoms, albeit in a supportive and structured environment, before he sees improvement. And he does seem willing to take those steps for his recovery. He does not have a large social network, but he understands that he will need support. Due to the abrupt onset of the disorders, the cooperation of the client, and the availability of effective treatments, the prognosis for his recovery is good. An immediate cognitive treatment objective would be to inform the client of the psychological and physical symptoms associated with the disorder, and using an ongoing psychoeducation approach in which the patient is made aware of each step in the process, thereby becoming a partner in the quest from hurt to healing. The client will be able to understand why he has been diagnosed with these particular disorders, allowing greater communication to occur in an open and direct manner, all of which will build trust and strengthen the rapport of the therapeutic relationship. The client will be asked to make daily, detailed lists of dysfunctional thoughts that he may be having in order to talk about them in therapy. The objectives would be identifying the roots of his depressive thoughts and helping him recognize how these thoughts are impairing his day-to-day functioning. Cognitive therapy challenges negative thoughts and develops healthier cognitive patterns and more positive beliefs about self and the future. Pharmacotherapy is a possible long-term treatment option for Scotty because he is having difficulty sleeping due to the nightmares associated with PTSD and because of his depressive disorder. Selective serotonin reuptake inhibitors, such as paroxetine, have proven effective with PTSD symptoms and depression and sleep disturbances. The client is not taking any other medication, so drug interactions would not be an issue. If he does not respond to that particular SSRI, switching drugs may be a consideration. Art making could be used as an assessment tool to determine the effectiveness of the medication. After 6 weeks of taking the SSRI, Scotty would be asked to draw himself before taking the medication and then to draw himself in his current state while on the medication, paroxetine. The process of creating art could be relaxing and therapeutically beneficial for the client and could be useful to increase communication between the client and the treatment team members to assist in successful medication treatment. Relaxation techniques should be emphasized in the treatment of all 3 disorders that Scotty has. Deep breathing exercises and meditation will be practiced with Scotty, and he will be encouraged to use those practices outside of the therapy sessions. Imagining a safe place creates a sense of security and control, along with the experience of confidence and dominance. Having a comfortable, relaxing place to retreat to in the mind will not only allow the client to reduce feelings of anxiety and stress, but will also allow him to gradually gain control over his physiological responses to trauma. Of course, every client is different, and therapy techniques must be tailored to fit the needs of each individual client. Scotty seems open to experimentation with different therapeutic techniques in the quest to find what will work best for him. In this current technological age, virtual reality simulators have become excellent tools for reducing the severity of symptoms associated with acrophobia. In weekly sessions throughout the course of several months, the therapist and client should address the phobia one step at a time. The simulator will steadily increase the height at which the client appears to be standing until he is capable of dealing with the feared situation. Once Scotty is able to confront his fears virtually, he can begin to gradually confront them in real life through systematic desensitization. Scotty reports having tried doing something similar to this on his own, using a step ladder that he would get on one step and look down and look up and be okay with the height that he was at. Then he would get on the next step up on the ladder, look down and look up and be okay with the height that he was at there. And then he would get on the third step, and that's when he would begin to have the fear and anxiety and the feelings of vertigo associated with the acrophobia. So it is important to use those similar techniques, but to not push him into it too quickly as he tried to do himself. Scotty's final goals are to come to terms with the traumatic events that occurred without having any psychological or physiological responses, and to return to his prior level of functioning before the traumatic experiences. Although eventually returning to the trauma is considered necessary, former adaptive defenses are restored and a safe therapeutic environment is established before traumatic memories are gradually and gently explored. There is no need to quickly push the client into talking about the events, because that could be very detrimental to his psychological state. Art therapy exercises can be used to guide the client in a safe and relaxed setting where he can comfortably retell his story of the traumatic experiences he suffered through. Projects like making mandalas about the nightmares and the traumatic experiences before talking about them can be very helpful in these situations. When he is ready, it may be helpful for Scotty to participate in a PTSD support group where he can build a network of people to share his story with, who are also survivors of traumatic events. The process may take a great deal of time before Scotty is able to achieve his therapeutic goals, but we as a treatment team should be prepared to help him with his journey to improved mental health. Thank you, and have a great afternoon.